name is Hannah Brosnan. I'm the Finance and Operations Coordinator with Mental Health America of Kentucky. Thank you so much for joining us for today's webinar, Introduction to Psychosis, a broad overview with an emphasis on early interventions. This is the first session in a statewide learning series designed to increase workforce capacity to address early serious mental illness and first episode psychosis. This virtual series is made possible by BSCA funds through Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. There are 8 total sessions in this series. I've linked this series in the chat should you wish to register for additional sessions. I've also shared the series schedule in the chat. Today's webinar is led by Dr. Ryan Melton, PhD, LPC, ACS. Dr. Melton currently serves as Dean of the School of Psychology and Counseling, Director of Assessment, and Associate Professor at Bushnell University. He is owner and operator of Endurance Counseling and Consulting LLC and clinical supervisor at Pace Health Hospital. Previously, Dr. Melton has served in a variety of director and university faculty positions. Thank you, Dr. Melton, for joining us. As you all know, this meeting is going to be recorded and is currently recording at this time. The recording will be shared via YouTube. Please make sure that you are muted and please put any questions in the chat and we'll get them answered during the Q&A portion at the end. I'll now pass it on to Dr. Melton.
All right, good afternoon, everybody. I only say that to you all because it's still the morning for me, but happy that you are here. Yeah, as Hannah mentioned, this is kind of our, I'm going to call it kind of our teaser trailer for a lot of what's going to be happening with the future trainings. I'm going to give a broad overview of kind of the importance of early intervention specifically with schizophrenia, although we're going to touch on psychosis and what that all means, and then ultimately lay the groundwork for other trainings in the series, some of which that I will be involved in doing. So there'd be a lot of the future trainings will expand on this particular presentation. Since I only have an hour for this one, and it's just each topic could go on forever. Which thankfully, Kentucky's allowed me to be able to do in the future, so I can go on a little bit more on future topics. So looking forward to that. Hopefully, this entices you to sign up for those future trainings. As mentioned, so yeah, really the focus. Oh, sorry, and then I'm going to go roughly 45 minutes or so. And so to give you all an opportunity to ask questions, you can go ahead and ask questions along the way. Just go ahead and type those in the chat. Hannah's going to be collecting those, and I will address those at the end. Okay, yeah, as mentioned, we're going to be talking about early intervention with schizophrenia and kind of the components of that. Specifically around how do we identify it? And once we do identify it, what do we do with it? And what should we do with it? So that'll be the kind of the talking points for today's webinar. All right, so one of the first things that we need to do, one of the more important things that individuals who work in early intervention programs need to do is identify when psychosis actually is psychosis. So when are we actually catching something early that we're really trying to prevent? And the mission for most early intervention programs is to catch schizophrenia early or major psychotic disorders early. However, the term or the experience of psychosis is not exclusive to schizophrenia or major psychotic disorders. It is, of course, can exist across a wide spectrum of other mental health conditions, medical conditions, as well as just being confused with other mental health conditions. So I'm going to go over a few of those because I think this is really important work. This is maybe the kind of the first step in when a referral comes through your door or a referral comes through a program's door that's focusing on early intervention. Young person's walking in and they're hearing voices or they're talking to themselves. What's going on? That's what we first need to determine. And if we think this is early schizophrenia, then that's going to be a good person, a good individual for us to be treating. If this is something else, then we may need to refer out because we can definitely go down the wrong path if we call something schizophrenia when it certainly is not. And it's much more complicated than you might imagine. And again, that's a nice a nice teaser for our future trainings where I'll go into this in a lot more detail, even break down several of these disorders you see on the screen and some of the characteristics of them as opposed and how they differ from schizophrenia. But again, psychosis exists in a wide range of conditions. Now, what I tried to do on this slide is do a direct line. So you'll see 1, 2, 3, 4, 5 direct straight blue lines, if you can see my screen well, from conditions that point to psychosis. What those direct lines indicate are those are 4 conditions where psychosis is part of that condition or is that type of condition. For example, schizophrenia. Obviously, schizophrenia is a psychotic condition. There's a direct link to psychotic symptoms in schizophrenia. Mania that happens in bipolar 1 disorder. There's oftentimes, not always, but oftentimes a direct link to a psychotic process. ASD or autism spectrum disorder. That is a higher rate of psychotic symptoms that tend to exist in ASD. Although, as you can join future webinars, we'll break down what's the difference between some thought processes that occur in ASD and psychosis, because that also can be confusing. And then psychosis can exist as part of medical conditions that are unrelated to mental health. And we certainly wouldn't want to miss that and call it a mental health disorder when in fact it is a medical condition. And then drugs, and when I say drugs, I'm referring mostly to illicit substances such as marijuana, methamphetamines, cocaine, hallucinogens. Those type of substances also can cause psychotic experiences, but are not necessarily schizophrenia. So, and then what I did, and with the direct lines, is I increased the font of the condition that is most likely to cause psychosis. So if you look at least of all those conditions would have the direct blue line, you're going to see the biggest one is drugs. So the most common cause of psychotic experiences is illicit substances, marijuana, methamphetamines, cocaine, hallucinogens, some of the synthetics, all can cause psychotic experiences. And our job as we work in early intervention programs is to then try to parse out, is this a substance-induced psychosis or is this truly more schizophrenia? Again, 2 very different conditions with 2 different forms of treatment. And then we have other mental health conditions and a little kind of wavy lines connected. So you'll see like stress, trauma, depression up here. Those conditions have what we call psychotic-like experiences as part of them. They look like psychosis, but they're not quite psychosis and may not be related to a primary psychotic disorder. So stress, any one of us could be put under such significant amount of stress that we get confused, we get disorganized, maybe we get paranoid. I challenge you all, don't actually challenge you all to do this, but if you are in a situation where you don't sleep for 5 days and put yourself under a tremendous amount of stress, things are going to get a little confusing for you. You know, we might refer to that as a benign psychosis related to stress. But so there's those type of things. And then we have depression. And certainly there is a diagnosis called major depressive disorder with psychosis, in which there is a true psychotic element to it. And then there's individuals that get depressed that will have really loud internal thoughts or intrusive thoughts, that might be perceived as psychotic experiences. They might hear their own voice saying, "You're worthless, you should die, nobody likes you," things that really are congruent to their depressive mood, but not fully psychotic. So those type of experiences. And then trauma. This is in a good portion of individuals, particularly adolescents who experience trauma, can result in what we call psychotic-like experiences, where the young person might start seeing things that aren't there, but they're not true psychosis, or they might start hearing things or become paranoid, but doesn't quite reach that full psychosis threshold, and is really more of a trauma-related disorder. So we certainly want to separate that group out from our first episode, because they require a much different type of treatment. In fact, most of those type of symptoms don't respond as well to antipsychotic medications. So we do want to make sure that our diagnosis is as accurate as we can be. Then you'll see a couple of other floating mental health disorders on the screen. ADHD, factitious are malingering, making it up. I oftentimes get questions about how do you tell if somebody's lying or trying to deceive you about their voices. We certainly do have those type of disorders in the DSM as well. Personality disorders can certainly be confused as psychotic conditions, particularly borderline personality disorder, schizotypal personality disorders. In fact, schizotypal actually may be related in a lot of ways to schizophrenia, and opposition defiant disorder. There's some of these disorders that are not really psychotic disorders at all, but can confuse clinicians. And then I've got a couple other areas that I wanted to bring our attention to. One, culture. I oftentimes get a lot of questions about, well, are we being sensitive to cultures that we don't understand, that may believe in spirits or the Day of the Dead? And, so they're almost experiencing something that we may not experience because we're not familiar with that culture. Is that psychosis? And of course, absolutely is not psychosis. So we oftentimes have to differentiate between cultural experiences that are much different than our own, but can be perceived as psychotic if we apply our westernized view of the DSM to what that individual's experience is. And so we have to be very cautious about that as well. And then finally, the other condition situation that we'll be talking, and we're actually going to touch on this a little bit today, and I will go into it in much more detail in some of our differential diagnosis trainings and early intervention treatment trainings, is APS, and that stands for attenuated psychosis syndrome. That's in the blue box to the right. That particular condition does fall in the schizophrenia spectrum disorders, but it's an attenuated for better or worse means kind of a lower level of psychosis, but actually is related to a psychotic disorder in many cases. This particular condition is really important in an first episode or early intervention with schizophrenia work, because this particular condition is almost our harbinger or a predictor of when somebody's developing psychosis, much more of a predictor of someone developing a true psychotic disorder than, say, a 13-year-old who's experienced trauma, who has a lot of psychotic-like experiences. So we're going to spend some time talking about that as well. So I hope what I'm pointing out is that one of the key features of an early intervention program is this differential diagnosis, and it's complicated. It's not just as easy as, oh, this person is hearing voices or is believing something that isn't in touch with reality, therefore it's schizophrenia. So symptoms of psychosis in and of themselves do not imply a diagnosis of schizophrenia, and we in early intervention programs need to become experts at this so we can refer people to the most appropriate treatment if it's not us. So let's talk about schizophrenia. So this is the disorder that we are trying to capture. And so what I have up here is your kind of your DSM definition of schizophrenia. I almost cut and paste it, right out of the DSM-5 TR to kind of just show you what those symptoms are. Not only show you what the symptoms are, but do a brief explanation of what these symptoms actually mean. So one thing that many clinicians, including well-seasoned clinicians, do not understand is the term active phase. It's the first word or set of words that you see in the definition of schizophrenia. So it reads, the essential feature to be diagnosed schizophrenia is that the individual must have an active phase that lasts at least a month. Active phase, what does that mean? Active phase means that the individual has, at some point during the course of their condition, lost touch with reality. That their symptoms, usually in the forms of delusions, hallucinations, or disorganized speech, have hit a severity level where it is causing functional decline, distress, and the person has lost insight. They no longer can tell the difference between what is real and what is not. That is the definition of an active phase. So what that implies is that somebody who has psychotic-like experiences, which we just discussed, would never meet criteria for schizophrenia because they still have insight intact oftentimes. Someone who meets criteria for an APS or attenuated psychosis syndrome doesn't meet criteria for schizophrenia. Might be at risk of developing it, but doesn't meet true criteria. And the reason for the differential is different treatments, different messaging, different approaches. So active phase, that has to be there for schizophrenia. So it has to be either an active phase delusion, an active phase hallucination, or an active disorganized speech. So an active phase delusion might be something like, the individual believes that you as a clinician are a shapeshifter, that you change your shape, you become other people and you follow them. And they believe that with 100% certainty. They'll maybe even accuse you of shape shifting. I'm saying this because I literally just got off a call before this message on someone who believes that some of our staff are shape shifting. So that's a full conviction delusion. That would count as kind of meets that active phase criteria. Hallucinations, hearing in schizophrenia, it's usually auditory, so hearing things that aren't there, but the person must perceive that as coming from outside of themselves and a true sensory experience. The hallucination is like you're hearing my voice now. Feels like it's not internal, it's not coming from in you, it's coming from outside of you, and it is a true sensory experience. That's how we separate intrusive thoughts versus hallucinations. Intrusive thoughts are not psychotic symptoms. Although young people, when you ask them a question like, do you sometimes hear things that other people can't hear? They say yes, but what they're really referring to is their own internal monologue and not necessarily a true sensory experience, which is the criteria for to meet a schizophrenia. Then disorganized speech. So then disorganized speech can confuse some clinicians too, just based on the term of disorganization. We use that term quite often in our day-to-day lives, right? Oh, I'm so disorganized, my work is so busy, I can't keep anything straight. And that may be true, but that is not how we define disorganization when we look at schizophrenia. We define disorganization as speech or behavior that has no end goal. So speech would look something like this. Well, I like talking to you all, and all or nothing, nothing is, there's the nothing. Have you seen the nothing? The nothing is these clouds. There's that one movie that came about in the theaters, and oh, popcorn is so good. Something like that where you just kind of heard me, it didn't make any sense. It didn't really have an endpoint. That's a true example of disorganized speech. And disorganized behavior also is this behavior that just doesn't seemingly have a purpose. So this could be wearing 8 coats when it's 90 degrees outside, public masturbation, putting rocks in your room or in a person's room without any purpose, those type of things. And then that one is not necessarily required for schizophrenia. Disorganized behavior. You're also going to have catatonic behavior. Catatonic behavior is this kind of rigidity in your movements, very rare and not always associated with schizophrenia. We now recognize catatonia as also being commonly seen in other medical conditions and mental health conditions. You can actually diagnose it separately from schizophrenia under DSM-5 rules. And then negative symptoms. And the term negative doesn't mean bad. It just means the absence of, so that the person has lost something that they used to have. So things like affects outward expression of mood, or not talking as much, or loss of interest in things they normally enjoyed. So to kind of clean up summarize the diagnosis, you have to have an active phase, so insight lost of either in the forms of delusions, hallucinations, or disorganized speech. Has to be one of those 3, and then one other symptom out of the list of 5, which then can include disorganized behavior or catatonic behavior and negative symptoms. Again, I'll go into this in much more detail, talk about secondary and primary negative symptoms. That's again a teaser for future trainings, but that's your overall kind of criteria. A little more complicated sometimes than we perceive schizophrenia to be. Okay, and that's what schizophrenia is, what we're trying to prevent. That's why early intervention is so important. Is that because you just heard me describe this, is that somebody has gotten to a point in their condition where they no longer can tell what's real or not. When people reach that point, it's harder to engage in treatment, because you can't go up and be saying, hey, it sounds like you believe the government is after you, believe that I'm shape-shifting. That's a neurochemical imbalance. We might have some medicines and some therapies that can help you with that. They're going to tell you to get the heck out of here, and that you are probably part of it. That's how we lose individuals in engagement when they have true active phase schizophrenia. But it does make it challenging when they have that phase. So if we can catch it early on, maybe even before an active phase, even better. This slide that you're looking at now is work of Barbara Kornblatt. And it kind of demonstrates the progression of true kind of schizophrenia that can work. We do believe that schizophrenia is probably present at some level, either at birth or even prenatally, but it doesn't really, the phenotype, the expression of schizophrenia doesn't really occur until post-puberty. So usually early signs we see in adolescence and early adulthood, with kind of the full-fledged disorder in your early 20s. So this really is a disorder of adolescents and young adults, and which why you see a lot of the age range of like 20 to 20, or sorry, 15 to 25, 12 to 30. You'll see age ranges like that in early psychosis, early intervention programs. But in studying individuals, what Dr. Kornblatt discovered is that there is a progression that tends to happen with schizophrenia before symptoms that we normally use to diagnose, which are these positive symptoms of schizophrenia. That's what I mentioned earlier: hallucinations, delusions, disorganized speech. Those are examples of positive symptoms. Again, positive doesn't mean good. Positive means in addition to. So it's adding something that onto the person's personality that they did not normally have, like hearing something, believing something that isn't there. But she believes that some of the earliest signs are cognitive challenges, before the onset of positive symptoms, that these individuals may be early puberty, maybe just pre-puberty, somewhere in there, start to develop cognitive challenges. So if they're in school, they really start to struggle in school a little bit. They'll describe their thinking as being confused, not thinking as clearly as they used to. That transitions into affective symptoms like depression. And when we do retrospective interviews with family members, it's not unusual that when I talk to a family member who has a child with first episode schizophrenia, they'll say, when he was about 13, 14 years old, we took him to a counselor because he was depressed, or we thought he had ADHD. So he started on Ritalin. Those actually could have been early developments of schizophrenia, those early kind of manifestations. Ultimately, it transitions to social isolation, where this is when now there's a real behavioral phenotype here that family members are like, why is my child not doing what they normally do? Are they on drugs? Do they have another mental illness? Again, we're still not seeing positive symptoms yet. We're still not talking about voices or anything yet. So they're trying to figure out what's going on. And then they start putting more pressure on the individual. And again, this is not me, please don't hear this as me blaming families. And this is what I would do as a parent if my child all of a sudden was doing terrible at school and was isolating in their room. I'm like, you need to get yourself out. You got to do something. You got to take care of yourself. I mean, I'd probably be putting pressure on my children as well. But those stressors then start to result in the increasing positive symptoms, which we then call, as positive symptoms are increasing, so either in the form of hallucinations, delusions, or disorganized speech, they're in an attenuated form. So the person still has insight. So they might start thinking, I believe that teachers can read my mind. I know that sounds crazy. I know that isn't real, but it really is. It's really bothering me. So that we call that an attenuated delusion. Those are kind of those early signs, but we don't see those until after a wide range of other symptoms. If the positive symptoms continue to progress, the person ends up going into what we then call active phase psychosis, where a diagnosis of schizophrenia can be made. And simultaneously, their functioning is declining, ultimately leading to disability. So our job is to kind of catch this as early as possible, either as the increasing positive symptoms are going up, trying to catch it there, or if we miss it there, catching it right as early as possible when they hit that active phase. The earlier we catch something, the better the outcomes. I'm going to talk a little more about what that looks like. So we know that kind of within Barbara Kornblatt's model, there are 3 phases of psychosis: a premorbid phase, an at-risk phase, has a lot of other names, called the clinical high-risk phase, and then the active phase, which we've now talked about. Premorbid phase, that's some of those early cognitive changes. We don't have tools to identify people in this particular stage. Where we do have tools is in the at-risk phase. We can and should be trying to identify people when they're have those increasing positive symptoms. And what else is also happening at this time? Their functioning is decreasing. And so that looks like if they're in school, their grades are dropping. If they're working, then their work performance is dropping. Their ability to parent is struggling. So their functioning is dropping. So that's what that black line represents on my slide there is functioning. So we have normal, quote unquote, normal functioning. Functioning is dropping while simultaneously positive symptoms of the psychosis are developing. Ultimately, that the person's their attenuated or at-risk symptoms become active phase psychosis. They cross kind of this crossover point where they go from believing something to be unusual, or maybe their brain is playing tricks on them, to now you're a shapeshifter. Then once someone hits the active phase, that's when we know it's harder to treat. And then there tends to be a time period between when someone hits the active phase to when they actually get treatment. We call that phase the duration of untreated psychosis, or DUP, because we need to have acronyms for everything, or DUP. And that's where early intervention programs need to react. The longer the DUP, the worse outcome. This has been shown in study after study after study after study. There's very few that really don't show that longer DUP, worse outcomes, either increased hospitalizations, increased disability, loss of family members, cost to systems, a wide range of negative, of poor outcomes when the longer the DUP goes. In this country, I think the RAISE study showed we're about, might be off a little bit, about 72 weeks, before someone gets treated. That's a long time to be fully psychotic or going in and out of psychosis in some cases. And one of the predictors of DUP, which is one of the saddest findings I've probably seen in my career, is that enrollment in a mental health program predicts DUP. The belief being that somebody may be enrolled in mental health, transitions to psychosis, mental health provider says, hey, you have psychosis, you should take this medicine, not recognizing that it's an active phase and how to work with that. Active phase individual says, you're part of a conspiracy, I'm out of here. And then they won't join treatment because now they think this is not real. So we see lose people. And we see this with hospital discharges too. Somebody discharges from a psychiatric unit, gets referred to a mental health agency who's had a first episode of psychosis, and they don't ever show up, or maybe they show up for a day. We start having them sign consents and say, yeah, you have a diagnosis of schizophrenia. The moment we start saying that, we lose them. There is literally a mental health center in my town where an unhoused person who's clearly psychotic sleeps right outside of that mental health center, but is not a client because he does not have any insight. And the way our system at least set up is that nobody's talking to him because he doesn't want help. It's one of the sad types of things that happens with schizophrenia, and why I think we have at least one reason for some of our unhoused problem is a lot of individuals with active phase psychosis where treatment may be available, but they can't get it, or they won't, or their schizophrenia prevents them from seeking help. And again, that's what we're trying to prevent. This is really where early intervention is most important, either in that late at-risk phase or as early as possible in the active phase is where we're going to get the best possible outcomes. If we can catch people in this at-risk phase, this is when people are seeking help. This is when they are coming to us, or their parents are bringing them in saying, this is when clients are saying, my brain is playing tricks on me. I'm hearing things. I don't know what's going on. Can you help me? They're a help-seeking population. Once you hit that active phase psychosis, it becomes a case-finding population. Like we have to go to them because they're not coming in. This is when crisis centers or mobile crisis units get called, or police get called because the individual is not coming into the mental health center. Because of their psychosis. You're going to hear me, I try to use the word attenuated psychosis because that's the term used in the DSM, but you're also going to hear terms like ultra high risk for psychosis, clinical high risk for psychosis, prodromal psychosis, attenuated psychosis syndrome, psychosis risk syndrome. These all generally mean the same thing. They're really that at-risk psychosis phase before the active phase of psychosis. And we do have valid and reliable tools that can help us identify people in that phase if we find them and we give them these tools. I'll talk more about those tools in another session. So yeah, in this clinical high risk phase or attenuated psychosis phase, about 90% of people who will go on to develop schizophrenia, we can then identify retrospectively that they had a prodromal or psychosis risk period. Now it kind of flips a little bit when we're trying to identify people. About 13 to 35% of people that score positive in some of our screening tools will go on to develop a psychotic disorder. Of course, it's not 100% accurate. You might say, well, that's not a very big number. It actually has higher predictive validity of conversion to schizophrenia than some of our pre-diabetic screenings, and we never stop doing those. So it's although it's not 100% accurate, it can predict whether or not someone's going to be converting to schizophrenia. And in this phase, if someone scores positive on one of our tools, we should be engaging treatment. Now, I'm not saying we're plowing them with antipsychotic medications. That is actually not the recommendation for clinical high risk for psychosis. It's actually more kind of talk therapies, monitoring, family work, those type of things. To meet this criteria, you still have to have attenuated symptoms of the three big symptoms of schizophrenia, which are delusions, hallucinations, and disorganized speech, but in an attenuated form, meaning reality is still intact. This is that arrow that I showed earlier going up, the progressing of positive symptoms. We can catch people in this phase, we can intervene, and some theorists, actually researchers believe we can prevent active phase psychosis altogether. And that's why they say some of these ranges between predicting is tough, because we actually are doing more early intervention and we're preventing onset of psychosis. Some people believe that, others say we can slow it, or at the very least, most believe if we catch it in the active phase and the person does convert to, if we catch it in the at-risk phase and the person does convert to active phase, we at least get much better outcomes. Just to give you an idea of what's an attenuated delusion versus a psychotic delusion. Attenuated delusion might be something like this. 15-year-old starts to sit in the back of the class because if she sits in front, she has a feeling the students are whispering and laughing about her. She might even start to hear them laughing, even though there may not be. She knows it's silly. She knows it's probably not real, but it's captivating enough, and it's beyond schoolyard or school bullying, that she goes and sits in the back of the class. I had a client almost just like this that started to believe that both kind of students and the teacher could read his mind, and so he went and sat started to sit in the back of the class, which then resulted in him missing a lot of assignments. So that's an attenuated. She knows it's silly. She knows it's not real, but it's captivating. It's bothersome enough that I feel better if I move away from those individuals. This on Barbara Kornblatt's scale is when that school failure and social isolation started to pick up. And then delusion, a full-blown delusion, is when a 15-year-old believes that people are talking about her, reads her mind, make fun of her wherever she goes. And the key word here is she is sure it is happening. She's 100% convinced it is happening. So she now isolates herself and doesn't go out in public because people can read her mind. Those types. That's a full active phase delusion at that point. Hallucinations and attenuated hallucinations, maybe 2-3 times a week, an individual starts seeing colors on the wall that are distorted. They hear beeping sounds, maybe last for a couple minutes. They may hear a voice, but it's very faint. They're not sure, but when you ask them about it, they think, it's probably my mind playing tricks on me. Still distressing, still causing some difficulty, but not a fully formed hallucination. Versus a fully formed hallucination that the individual believes that they are hearing voices that clearly are speaking to them, that these voices are coming from outside of his head. They refer to him in third person. They criticize him. They might even tell him to do something silly like pat the cat. He believes they're real. It's happening to him. It's kind of disorganized, doesn't make sense. Things like pat the cat. It's actually typical of kind of schizophrenia hallucinations versus the type of other forms of hallucinations that we see in depression and trauma. So how do we treat it? Both either early episode attenuated psychosis or clinical high risk for psychosis and first episode psychosis means still the best evidence we have in terms of treatment is coordinated specialty care. And coordinated specialty care is when we wrap several services around the individual who's impacted by psychosis, the support network, the families, and in that case, using the family system, although it could be anybody that the person finds supportive. And we wrap around counseling, support employment, peer supports, some cases occupational therapy, substance use treatment, psychiatric care, case management. These services vary across different coordinated specialty care teams, but it gives you an example of the type of treatment that tends to be used with these individuals, and the type of treatment that happens in early intervention programs. And then, what do those treatments look like? So I'm going to just give you a brief example on a few. I mean, we might be using CBTP, or cognitive behavioral therapy for psychosis, where we might be using insight-oriented strategies, where we can do reality testing with clients at the at-risk phase. Case management is focused on resources around stress reduction as opposed to disability resources like SSI. We really don't want to go down a path of supplemental security income early on. Family education, that we might be talking about what's happening, working with our family, our support systems on what's happening, telling them really not to panic, focus on normality. We're monitoring this. It could be something serious. It could not. We do know with early intervention that we've caught it early, and we catch things early, we can usually prevent bad things from happening. Substance use, we're really, if they're using particularly marijuana is the substance that is most predictive of conversion to schizophrenia. It converts at a higher rate than methamphetamines or heroin. So it can be a dangerous substance for people in the at-risk phase. So if they're using this, we need to be addressing it. We can do work and school supports, because we want people to graduate. We want them to stay in school. We do know from Barbara Kornblatt's work that this is a phase where people are starting to struggle in school if they're at that age. So we want to get supports in there. So we call them kind of supported education specialists that go in and maybe help us get set up a 504 or an IEP if needed. Go in that direction. Peer supports, someone of the similar age and interests, not necessarily the same disorder. OTs can help us start addressing some of those cognitive declines that, again, I mentioned earlier, are present prior to the onset of positive symptoms. So they are present in the at-risk phase. So we do want to make sure that we're trying to address those cognitive symptoms. Prescribers, again, APA, American Psychiatric Association, recommends that medicines in this phase, at least antipsychotic medicines in this phase, are not used. However, there still could be other medicines used, antidepressants. There's some evidence to suggest that could be helpful. Either way, we should be monitoring metabolic risks and other health risks with these individuals. And then again, ongoing monitoring. And there's some specific scales that I'll go into more detail in future trainings that we would use to monitor whether the individual is moving towards converting to first episode psychosis. Because really our goal is, if we catch people in this at-risk phase, that they don't convert to first episode, and we really do try to prevent that. And of course, we have to catch it, right? I mean, early intervention really only works if we catch it. So we have to do community education. This is one of, in Oregon, the ESA program is kind of the statewide leader in early intervention work. There's their website there. There's a picture of one of the posters that actually I and one of my colleagues created with an artist and a focus group of young people. So they designed it all. They gave us the language to use. I actually gave them some of the scales that we used, or some of the screening tools we used to assess for psychosis. And they picked out the ones that they think could be that people of their age might most recognize. And then, we create a bunch of these posters and hung them up all over schools, put in a QR code, put in a quick text, to try to get people recognizing these symptoms as early as possible. Beautiful thing about this focus group that I was involved in, almost all of the young people, and these were like 16 through 18-year-olds, were all saying, my friend was starting to hear voices. I really want to help them. To me, that was just so heartwarming. It's like, have we finally done something to start to reduce stigma? Like, they weren't scared of their friends. They wanted to help their friends. So what a great opportunity for us to really catch this as early as possible. And by the way, their advice on where to hang these up inside of bathroom stalls is where they told us to hang these posters. Most private spot and a place where everybody tends to focus. So. And then finally, just very quickly, and I think I've covered this a little bit, is that active phase of psychosis. This is, again, when someone hits the active phase, this is only then can you really diagnose a schizophrenia, schizoaffective disorder, schizophreniform disorder, brief psychotic episode, delusional disorder, all those disorders that the DSM-5 TR lists, those can really only be diagnosed if the person doesn't meet an active phase definition. We all use the same treatments, with active phase that we do with coordinated special care. At least in the overall approach, we still use cognitive behavioral therapy for psychosis, or case management, or family psychoeducation, and substance use treatment. But we modify them a little bit. For CBTP, for example, we may use non-insight oriented strategies, things called collaborative empiricism, focus on coping, focus on functioning in spite of you believing that I'm a shapeshifter. I don't have to CBT at this stage, or this type of CBT, one of the goals isn't necessarily to reduce the symptoms, because sometimes when people hit first episode or that active phase, even with medicines, sometimes particularly delusions don't necessarily go away, but we still need to treat people. So oftentimes we're focusing on how do you function, and how do you meet your goals, even though people shapeshift? How do you ignore it? How do you kind of work around it? Those type of strategies. Case management might be a little more assertive, reaching out to, going to people's homes. It might be focused on some eligibility entitlements like SSI if the person does have some treatment resistancy to their condition. The family psychoeducation, again, very similar, but the information is more around schizophrenia, more structured problem solving with this group, and then maybe more structured substance use treatment with this particular group than our clinical high risk group. More structured, you're going to hear me say it over and over again. And when we get into trainings or treatment webinars, I'll go into these more detail, but more traditional evidence-based support employment practices. People might be familiar with the IPS model, the individual placement and support model. A really well-researched model tends to work well with more first episode versus clinical high risk. You can, with our peer supports, more shared experience of psychosis can be discussed. OT still working on assessments around cognition and trying to work on that. At this phase, the research is going to recommend, probably at the very least, a low dose antipsychotic medication at this particular phase. In addition, some actually even have gone as far as recommending higher dose medicines, being a little more aggressive depending on the symptoms. And then in terms of monitoring, we use different tools. At this point, we're no longer monitoring for conversion to schizophrenia and trying to prevent it. We're monitoring now specific symptoms and trying to reduce those. So different monitoring and assessment tools that we use at this phase. But overall, considerations in implementation of early schizophrenia projects. One, we need a common language and understanding. We need to know the difference between clinical high risk for psychosis and active phase psychosis. We need to know what clinical high risk for psychosis is, or this at-risk phase is, and what it's not. And we need to accurately diagnose it. And I do believe we do need a standardized diagnosis process. I'm a SCID trainer, so that's a structured interview for DSM-5 disorders. I like that instrument to really help us pin down what's happening. And this can also help us rule out some of those symptoms that I talked about earlier, like trauma or depression or autism spectrum disorder. And then having specific stage-based treatment recommendations. So it's not just, we'll give everybody CBT. It's stage-based CBT, using CBT has better evidence when someone's in the CHRP phase, and then using different forms of CBT, or at least different CBT interventions when someone's in the active phase of psychosis. And so knowing those caveats. So we used to argue whether or not we should even do early intervention. And we're beyond that argument now. We know that early intervention is effective in a wide range of medical conditions. Early intervention in cancer is very effective. Early intervention in diabetes is effective. Early intervention in substance use is effective. So we know it works. So we should be doing it with major mental illness like schizophrenia. So it's no longer a matter of should we do it. The question that we're all still struggling with, or we're trying to put together, is how do we do it? What tools do we use? What interventions do we use? How do we engage individuals? That's still kind of the question, our primary question now. So it's not yes or no, should we do it? It's no, we should do it. How should we do it? Is the question we need to be struggling with at this moment. And that's a cat. And the only reason I have a cat is because sometimes I've just given you a ton of information in a very short amount of time. It was somewhat intense. It may have activated your sympathetic nervous system a little bit. So research says, throw a calming image up onto your screen. Let people relax a little bit as they kind of take in that information. Set them back more into their parasympathetic system so that they can ask any questions that they may have of the presenter. So there you go. Thank you very much. Again, that was my full-fledged teaser trailer for future trainings, but wanted to give you at least an overview of early intervention in psychosis. I'm happy to answer any questions you have.
Hello, my question is, are these diseases not actually classified by doctors in the first place? Is it not something like a man-made categorization of diseases?
Sorry, you're breaking up. I couldn't quite understand the question. I wonder if you could type it in the chat and then maybe Hannah could read it to me. Yeah, I just couldn't quite understand it.
Dr. Melton, I did receive one question.
Thank you.
Claudia, if you wouldn't mind to just go ahead and type it in the chat and I can read it for you. And anyone else, if you have a question, feel free to type it in. We do have over 30 people in here right now, so just so that we can help avoid talking over one another. Yeah. Dr. Melton, one person did ask if this slideshow will be directly available, or is it best to just access it through the webinar recording?
It is you're going to be available, correct?
Yes, they're asking if we can send it to them. Okay.
Yeah, if you reach out to me, that would be fine. You can PDF it and send it to people. Yeah.
Okay, wonderful. Thank you.
Yeah.
I do see someone in here asked if in the chat or the Q&A area, just go ahead and put your question directly in the chat, please. Thank you. Clarissa asked, what was the SCID assessment? Is that what you said?
Yes, I did say the SCID assessment. The SCID assessment stands for Structured Clinical Interview for DSM-5 Disorders. It is the questions that kind of follow the diagnostic decision-making that the DSM wants us to do, but the DSM itself doesn't tell us. All the DSM does is list criteria, right? And we'll say, disorganized speech, hallucinations, kind of the stuff that I put up on the training. Doesn't tell us how to assess for those. The SCID is the supplemental manual to the DSM that kind of gives us those decision tree questions in the order that they're supposed to be asked. So we make sure that we have essential features of the diagnosis so we don't unintentionally misdiagnose individuals. So yes, structured clinical interview for DSM-5 disorders, the SCID. Highly recommend its use if you're get involved in this type of work. And honestly, it's just a good diagnostic tool, frankly. But I like to use structured instruments. Structured instruments do increase validity of diagnoses. They also, one thing we do know about diagnoses in general is that there is racial bias in diagnosis. We have Black Americans tend to be overdiagnosed. However, we can reduce that by using structured instruments. So it also can help us kind of reduce our own biases by using more structured instruments.
Thank you, Dr. Melton. Another question for you from Claudia. Are all DSM diseases man-made categorizations, such as the checklist to diagnose mental illnesses?
Sure. I mean, yeah, I know you're kind of going, I think I know where you're going with this type of question. Certainly the DSM these are a set of clusters of symptoms that we have identified. We've identified, what I will argue is that we've identified pretty specific patterns of people over time that we can start to then place them into categories. And then these specific categories, in many cases, certainly not all, do respond to specific treatments. And that's where DSM diagnoses can be helpful. I also recognize the limitations of the DSM, being that it is not something that, I mean, we can't diagnose mental health conditions based on brain scans, right? We don't have blood work that, that I can't run your blood and say, oh, no, there's schizophrenia right there. That we can't do that. And that's been a criticism of mental health disorders for decades. But I also will argue that it's using structured instruments kind of the best that we have. And not everything has these kind of hardcore concrete roots. I mean, if that were the case, if everything was completely measurable in an objective way, then we should probably be doing EKGs for heartache. I just think that there's a combo of subjective and objective when it comes to the DSM for sure. Thank you. That's a great question. I love those kind of questions.
Thank you. Another question from Casey. In which training will you share the effective assessments for finding clients who may be showing early symptoms?
Oh, which one is that one titled? That's probably going to be the focus on CHRP, clinical high risk for psychosis. So I'll go over those in more detail.
Okay. And Casey, that's the one on Tuesday, May 23rd. And I will make sure to send the graphic with the schedule and the Eventbrite link at the end as well. All right. Question from Christy. She said, great information. Thank you. Will you please provide more examples of how OT is used in treatment?
Yeah, I will certainly get into that in both the FE, the first episode, and the CHRP modules. But briefly, our OTs will use things like the sensory process, the adult and adolescent sensory profile. Sorry. And so they'll use, because we know that there's a lot of sensory challenges and sensory integration challenges with individuals both developing schizophrenia or who have schizophrenia. So we'll use those type of tools to give us more treatment recommendations. Maybe, when I'm doing therapy, this particular client has a light sensitivity, so we can reduce the lights, or have low sensory integration, so I have to provide fidgets. Just that type of really cool type of sensory stuff. In addition, we have a few cognitive measures that they'll use that we can kind of help identify where there might be some cognitive deficits, so we can guide particularly IEPs and 504s in school systems, as well as workplace accommodations, is where our OTs are helpful. That's just a couple of the more assessment examples, but that's not even getting into the day-to-day functioning ADL work that they'll do, which is amazing.
Christy says, thank you. And Christy, just so you know, we also have another FEP session on June 8th, which will focus on occupational therapy and behavioral health services as well. All right, looks like we've got all the questions in the chat right now. Does anybody else have any other questions? Well, what I'll do is I'll go ahead and again, review this series quickly. Oh, here we go. We have another. Have there ever been discussions on recreation therapy?
Yeah, there certainly have. And there's a few published articles specifically looking at recreation therapy for schizophrenia. My opinion on other forms of therapies that aren't specifically called out in coordinated specialty care is, let's do it. I mean, we haven't completely nailed it with coordinated specialty care, and we still haven't been able to isolate which specific element of coordinated specialty care is kind of the gold standard, or which combination of elements is the gold standard. We just kind of know it works. And I'm of the belief that I think it works because it's a wide variety of treatment approaches and it gives people choice. And I think that may be the most predictive factor in why coordinated specialty care works. So if somebody would be into recreational therapy, I'm all in. I have a colleague that's doing EMDR with psychosis, which when I first started training, they said never do this type of work, and now it's being done effectively. So I think we should be thinking outside even our coordinated specialty care box to really kind of meet the needs of clients. So yeah, absolutely.
Thank you. And another question. Sally says, lately I've been conceptualizing delusions as on a continuum from normal, I'm not going to eat that pie later tonight, she says, to psychosis. Does that match your experience with clients?
Yeah, absolutely. I mean, I don't think they're binary, right? I think most of the delusions do kind of come on a spectrum. I mean, even the individual that is currently believing that our staff are shape-shifting, at times that isn't, as he might be more in a, I think you were shape-shifting. You might have been in my TV last night, but I'm not sure, to you were in my TV last night, get the heck out, which is where he is right now. So we're trying to provide some different types of intervention for him. So certainly goes along the spectrum. And that's great if clients do have that. You use that, right? And that's kind of part of a cognitive behavioral therapy approach of, the other day you were kind of saying that maybe I wasn't in your television. Can you tell me what was going on then? What's the difference? And so you can start doing some work in that end.
Thank you very much. All right, it looks like we don't have any other questions right now. We have some folks saying thank you and that they're looking forward to the next training and that this has been helpful. I am going to go ahead and send some additional info in the chat and just review a couple things. If anyone has any other questions before we wrap up, please feel free to put them in the chat while I'm talking. I have gone ahead and put in the chat that additional information on the remainder of the first episode Psychosis series. Our next session is on May 22nd. I've also included the post survey. Through that post survey link, you can request a certificate of attendance. I see someone here asked if the slides will be shared. We can send those as Dr. Melton has given us permission, along with the link to the YouTube webinar recording that will be ready within the next week, and we'll make sure to email it to all of you. The live training is eligible for social work CEUs and may be eligible for additional CEUs as well. Again, those certificates of attendance are available via request through the post survey. And that link will be sent via email with the webinar recording as well. If you have any questions, please feel free to reach out to our Executive Director, Marcy Timmerman. Her email is there in the chat. And I'm going to check and see if we have any other questions before we wrap up. All right, I don't see any others. Dr. Melton, thank you so much for your time for this amazing webinar. Thank you everyone for joining us, and we hope to see you on the 22nd.